vaccines against invasive pathogens may reduce antimicrobial resistance. I think that probiotics can be useful in specific conditions, as for example in gastroenteritis or in other complicated infections as C. diff.
And finally, if you could give one piece of advice to a GP or midwife about protecting children from infection without over-relying on antibiotics, what would it be?
Yes, vaccinate on time.
Welcome to the final instalment of our deep dive series. I'm your host, Dr. Saranya Ravindran, and it's time to wrap up our conversation with today's guest. So you studied both vaccine-preventable diseases and post-vaccination immunity. How does vaccine coverage intersect with antimicrobial stewardship?
High PCV, Hib, and meningococcal coverage prevents invasive disease and reduces empiric broad-spectrum use. So it is important to remember that vaccination against invasive pathogens reduces antimicrobial resistance. And in addition, early life antibiotics may blunt vaccine responses, reinforcing the need to avoid non-essential exposure.
So is what you're saying that if someone has been given vaccines, the likelihood of them responding well to antibiotics might be better?
Yes.
Okay. That's very interesting and something that I will definitely use as part of my vaccine hesitancy discussion. So what are some of the most promising vaccine candidates or strategies currently in development for reducing the infectious burden in children?
First of all, improved RSV prevention strategies. Then next generation pneumococcal conjugate vaccines with broader serotypes. And finally, the new meningococcal formulations in development, each with potential downstream reductions in antibiotic use.
And now you've also published quite widely on the gut-lung axis, the microbiome-related outcomes. How does early life microbiome disruption from antibiotics relate to chronic conditions like asthma or autism?
Evidence links early antibiotics to increased risk of wheezing or asthma. This is an association, not proof of causation. Microbiome disruption is a plausible pathway. Data for autism remain inconsistent, so stewardship minimize anyway this avoidable exposure.
And how about the neurodiversity presentations? Is there any evidence about the gut-lung axis in that?
Yes, absolutely. The link is between the gut-lung axis for wheezing and asthma and the gut-brain axis for autism.
Is there a place for microbiome-targeted therapies then, or even microbiome preservation as a form of preventing those infectious diseases?
Emerging, so probiotics and prebiotics or microbiome sparing strategies may mitigate vaccine response blunting after neonatal antibiotics, but clinical protocols aren't standard yet. So there is space to watch at what will happen in the future in research.
And is that something that you personally recommend for your patients? Would you offer them or suggest that they take therapies for the microbiome?
I think that probiotics can be useful in specific conditions, as for example in gastroenteritis or in other complicated infections as C. diff. In addition, when there is a need to administer oral antibiotics for a long time, probiotics can be extremely useful. Anyway, it is important to remember that the evidence exists only for some probiotics, and it is important to use probiotics only when there is evidence.
Bacteriophages are gaining interest as alternatives to antibiotics. Can you tell us a bit about what they are and the current barriers to their use in children?
So bacteriophages are viruses that infect and destroy bacteria. The name literally means bacterial eaters. So they attack to a specific bacterium, inject their genetic material, and use the bacterial cell to make more copies of themselves. However, there are some problems in regulatory pathways, manufacturing and standardization, narrow host range, and there are limited pediatric randomized control trials. Compassionate use exists, but routine pediatric respiratory indications need better evidence.
So who might be the candidates for this kind of therapy?
Oh, I think that they can be considered in patients with resistant infections that cannot be treated with standard antibiotics.
Okay, that's very interesting. So something we talk about a lot on this podcast is about AI, and I would love to know how you think AI or predictive analytics can change antibiotic stewardship programs in the next 5 to 10 years, especially for individualizing care for patients.
Yes, I think that it can be very useful because AI can permit to link bedside decision to local PPS, to antibiogram data and patient factors. And this can permit to tailor empiric choices and durations. So I think that can have a relevant impact.
And finally, if you could give one piece of advice to a GP or midwife about protecting children from infection without over-relying on antibiotics, what would it be?
Yes, vaccinate on time. Teach symptom-based home care for viral illnesses. Use delayed backup scripts sparingly and schedule a 48 to 72-hour review before committing to antibiotics unless the child is clearly high risk.
Thank you. Those are really very useful tips. And I think it's something that we all need to be mindful of. It can be quite difficult, I suppose, with the 48 to 72-hour reviews where primary care can be such a stretched system. But the ideal would be if we could all do that, we should, because I think, as you say, it would be a great way to prevent over-reliance on antibiotics and hopefully prevent resistance getting worse. Professor Esposito, thank you so much for sharing all of your expertise today. It's been a great conversation in the theme of antimicrobial stewardship and understanding all of your experience and the research that you've done and how that has helped build those protocols and principles to make antimicrobial resistance less of a problem in the future. And I really do hope that some of those things are carried forward. So thank you so much, and I hope you enjoy the rest of your day.
Thank you very much.
And that concludes our deep dive series. Thank you for listening to the EMJ podcast, and we hope you've enjoyed the conversation. Until next time, I'm Dr. Saranya Ravindran. Stay safe, stay well, stay curious.